Hi there, how's it going? My name is Catalina Rojas, and I'm here to talk to you guys a little bit about what CO2 monitoring is, how important it is, and why should the intensive care unit at Kindred Hospital should have it. How will patients benefit from it as well as staff? So let's get started on that. So as we all know, safety is extremely important, right? We want to deliver high quality health services, and in order to do that, safety should always come first. According to the World Health Organization, the occurrence of adverse events due to unsafe care is likely one of the 10 leading causes of death and disability in the world. In order to ensure patient safety, all hospitals must consist of having clear, straightforward policies for their employees, safety strategies being reinforced, working equipment, skilled healthcare professionals, and of course, leadership capacity. So the purpose of this presentation is to propose to the CCO at Kindred Hospital and the respiratory director to install capnography monitoring in the intensive care unit of the hospital. We will look at what capnography is, the benefits of having capnography monitoring in the ICU, what equipment will be needed, and of course, a cost and benefit analysis will be given to fulfill this proposal. After this topic is presented, I'm hoping for this project to get started in hopes of installing CO2 monitoring in the intensive care unit, and as a result, this will help prevent airway-associated problems and increase ventilator weaning in our patients. So what is capnography, right? The term capnography refers to the non-invasive measurements of the partial pressure of carbon dioxide that's being exhaled on every breath. CO2 monitoring can make a difference on the care provided, and it contributes to the prevention of fatal accidents. For example, in a study done by Elliot Warner on the impact of capnography on patients' safety in high and low income settings, her research shows that retrospective and non-randomized data suggests that the use of capnography monitoring can improve results in the ICU, emergency departments, and during resuscitation. So obviously we have that tool to help the staff. The outcome of a patient surviving, doing better is likely higher where compared to not having it. Kindred Hospital San Francisco Bay Area currently does not have any CO2 monitorings in their ICU. Data shows that the lack of CO2 monitoring contributes to delayed detection of complications on patients with an artificial airway. A study done by TICO on critical incidents reporting in intensive care unit states that monitors responsible for detecting incidents were the pulse oximeter, ventilator alarms, hemodynamic alarms, and tidal CO2 monitorings, and cardiographic alarms. Clearly, CO2 monitoring can make a significant difference in preventing patients' incidents. So how does capnography work, right? It's very important to always monitor any patient admitted to any hospital, especially those who are in the intensive care unit, because this is where we have the most critical patients. Capnography allows to non-invasively provide medical staff with a continuous display of a patient's CO2. Capnography works by using a sampling line that's able to capture, monitor, and test a patient's exhale breath either from their mouth or their nose. After a patient's breath is captured by this line, the CO2 is then able to pass through a special sensor located either in the airways tubing outside the nose or the mouth, or it's placed in a separate analysis chamber. CO2 levels are then detected after a beam of infrared light passes over the gas. CO2 can then absorb infrared light at a specific wavelength. As a result, high infrared light passing to the detector indicates low levels of CO2 being present, and low infrared light to the sensor means high levels of CO2. The increase and decrease of CO2 concentration over time during respiration is then translated onto the capnograph, which is what we're able to see on the monitors. So currently, the only way to monitor the effectiveness of ventilation at Kindred Hospital is to perform arterial blood gas. This obviously requires costly testing and increased pain and risks to the patients. According to a study done by Kenneth Miller on reducing arterial blood gas measurements in the intensive care unit, he determined that approximately 42% of laboratory testing being done in the hospital is either wasteful or unnecessary. In fact, any unnecessary laboratory testing that's done in the hospital stay is linked to hospital-acquired anemia, resulting in a significant increase in morbidity, increased length of stay, and of course, increased frequency of blood transfusions. In this study, an intervention to decrease inappropriate ABGs was introduced within the intensive care unit. These interventions including educating doctors, respiratory therapists, and nurses of the uses of end-tidal capnography. The intervention was so successful and resulted in a 22% decline in ABGs, reducing the risk of hemorrhage, distal ischemia, nerve damage, and infection, and many other possible complications. So, of course, the less invasive, the better for the patient, and of course, the less money we also spend on this. Capnography monitoring in patients with an airway is very useful, for it can give us a real-time and continuous information on the patient's artificial airway patency and placement. Proper endotracheal tube placement must be verified every time a patient has been intubated. Unrecognized misplaced intubation has disastrous consequences and has been extensively documented in emergency medical services literature, with reported rates ranging from 7 to 25%. Complications of wrong ET tube placement includes if the ET tube is too high, it can rub against the vocal cords and cause cord trauma. If the ET tube is too low, it can selectively intubate the right or left mainstem bronchus, and esophageal intubation can occur if progressive gaseous distensions of the stomach while the lungs volumes remain low is noticed. A change in capnography waveform lets the staff know that there might be some kind of problem in the patient's airway, and as a result, it can trigger immediate assessment and response to this change. Capnography has a fast response time, which changes in the capnography waveform usually seen before a change in oxygen saturations. A 2011 audit of major airway management complications in the United Kingdom estimated that 82% of events resulting in death or brain injury in the intensive care unit likely resulting from failure to use capnography in relevant cases. The same audit concluded that half of the deaths that occur in the UK emergency departments could have been avoided had capnography been correctly used and interpreted. So being able to detect the problem and then work to solve it is effective problem solving that can have a major impact on patient well-being. CO2 monitoring can also assist the healthcare worker by monitoring how well a patient is ventilating. CO2 monitoring allows to detect hypercapnia due to hypoventilation, hypocapnia due to hyperventilation, and it can also be useful when weaning patients for ventilatory support. It gives us information about trends and efficiency of ventilation and perfusion as well. Capnography allows for the trending of the CO2 value, and it's a subsequent comparison with ABG values. Unlike pulse oximetry, capnography does not misinterpret motion artifacts and provides reliable readings in low perfusion rates. CO2 monitoring during CPR is also very important. Whenever a patient is in respiratory or cardiac arrest, CO2 monitoring allows healthcare workers to know how efficient and adequate are the chest compressions that are being given. It also lets us know whenever a patient has had return spontaneous circulation during cardiopulmonary resuscitation. Successful resuscitation from cardiac arrest depends on provision of adequate blood flow to vital organs generated by CPR. Measurement of end-tidal expiratory pressure of carbon dioxide using capnography provides a non-invasive estimate of cardiac output and organ perfusion during cardiac arrest, and can therefore be used to monitor the quality of CPR and predict return of spontaneous circulation. Deciding when to stop resuscitation efforts is one of the most difficult decisions any doctor can face. CO2 can help differentiate when efforts should continue and when they are unsuccessful. In patients receiving high-quality chest compressions who have an advanced airway place a persistent CO2 reading below 10 after 20 minutes of resuscitation is an indication to terminate efforts. However, a high CO2 shows that CPR is providing effective circulation to vital organs, essentially doing the heart's job while defibrillation and medications are administered to get it beating on its own. Therefore, the chances of getting the patient back are then higher. So now that we know some of the benefits of having CO2 monitoring in the intensive care unit, let's talk about the cost and benefits analysis that we need in order to continue with this project. So as of right now, the ICU rooms at Kindred Hospital currently have a Dynoscope monitors. These monitors do have the ability to incorporate CO2 monitoring. So there are currently 10 beds in this ICU, all with the same monitor. Unfortunately, the cables that go from the monitor to the patient are nowhere to be found in the department or anywhere in the hospital in general. So the first thing we need to do is order 14 of the Fuduca Denshi Dynoscope CO2 sensor cables. The monitors all work, so instead of buying new monitors, it will be cheaper to just buy the cables, and those can be found online on this website. If you go in there, you see that these cables are being sold at a price of $350 each, but when buying more than 5, you obviously get a discount, so instead they come out to $320 for a grand total of $4,480, not including taxes. Other items that will need to be purchased are the Zoll disposable airway adapters, these little adapters here. These adapters are single use and they come in a box of 10. After doing some research, the most economic ones can be found on this website, azentosdepot.com. And each box is sold for $116.20 plus tax. So the estimated amount of dollars needed to get this project started is $5,500 just to get it started, right? So we do have to keep in mind that the CO2 sensors will have to get reordered every so often depending on how many patients we're using. Of course, we also want to be stocked so that whenever a patient is transferred to the ICU, we're able to connect them to the monitor, or maybe we need to replace them. So keeping an eye out for the inventory will be managed by the director and purchasing manager. So most acute hospitals have a revenue charge of $700 to $900 for CO2 monitoring. So I'm thinking that the daily charge drop of $750 for every patient in the intensive care unit that requires CO2 monitoring will be good. So RTs, nurses, and doctors will be taught how to use this tool. The teaching can be done while by the lead RT, or whenever we have a scales fair. The intensive care unit remains occupied to its max capacity most of the time. Patients get admitted and then transferred to a different floor periodically. So the money will exceed the money that was spent on the equipment or training. And of course, we will see an increase of money coming in from the department from starting to use CO2 monitoring. So in conclusion, installing CO2 monitoring in an intensive care unit of Kindred Hospital will aid in increasing patient safety and reducing airway-related accidents. A budget has been given to get this project started, and although there will be a small cost, the benefits will outweigh the drawbacks. CO2 monitoring in the intensive care unit is done in all acute hospitals, for it is a key component in the monitoring standards of most ICUs. It is a valuable monitor tool as it provides critical data about a patient's cardiorespiratory status. It's time for Kindred to take a step forward in improving patient safety and reducing airway-related incidents. Thank you.